back on stage again. So Srinivas actually dropped me this topic, and very interestingly, I've been single all my life, and one of the reasons was I found women being very complex creatures, and so I avoided them. But unfortunately, in the work that I did, now it looks like they call me a maverick in female airway health. So I'll try and show you what is these things that have come up recently. And if you look up literature, there's actually not much in literature. So a lot of the data that I'm going to show you is actually what I've been observing in our studies. And I think at the end of the talk, one realization that you'll come to realize is women are very important. And forget about human rights, I mean female equality and all that. I think what is very important is we as men have to learn how to support women to ensure the health of the future generation of the human species. That is how important they are. So, my usual disclaimers. OSA in women. Up to date, up to very recently, OSA has been seen traditionally as a male disorder. And only after menopause, we come to equal terms. But as in everything else about gender equality, they always fight they want to be equal to us. So welcome to the realm of sleep disordered breathing. They are as bad as us, if not worse. It's much more complex because as far as women is concerned, they always like to make things complex. In terms of symptoms, diagnosis, consequences, and also treatment differs significantly. So the current prevalence studies may reflect the current situation. The females are being diagnosed and treated in OSA less frequently than males, and that's a fact. Because first of all, the symptoms that they present with is not something that we are seeing in ENT. Who are seeing them? The psychiatrists, the psychologists, musculoskeletal people, orthopedics, chiropractors, because the symptoms have got, they don't even realize they have a breathing dysfunction. And a lot of the times when they come to me, what I actually get them is, they don't tell me that they have symptoms, they don't even come. So I'll give you another good reason why when you have the husband there, you want to have the wife for the history. One of the things you can actually pick out is you can actually pick out sleep disordered breathing. So I'll give you an example of what actually happens in the clinic. The husband is usually forced by the wife to come to get the snoring sorted out. And so the complaint is always coming from the woman, snoring, he snores very badly, I can't sleep, blah, blah, blah. And then once you start going on, and then you say, actually, you are a worse patient than him. And they'll be like, what? I say, you have neck pain? Yes. Shoulder stiffness? Yes. Have you had bicuspid extractions with braces? Most of the time it's yes. Do you have low back pain? Yes. Do you have problems falling asleep? Yes. Do you have sleep fragmentations? Do you get up multiple times? Yes. How many times do you go to the toilet? 2 to 3 times. And these are not old patients. These are patients in their 30s and 40s. Do you feel tired? Now, if you ask a man this question, we are always tired. We are the lazy ones. But ask a woman if she feels tired. Women don't understand the meaning of the word tired. So there's a very clear subjective difference between the same word but different different meaning to individuals. Women, even if they wake up tired, they don't think of it because they still have to get up, do whatever work that they need to do. So it's very subjective. But when you really sort of delve into it and you tell them, do you really feel tired? Yeah, doctor, I feel tired all the time. But they don't complain. For them, it's very different. Anxiety, do you get panic attacks? Yes. Do you have compulsive behaviors, like if you're planning for a holiday 1 month before everything has got to be in the right place at the right time? These are the symptoms that we're actually looking at. And then suddenly it's just an outpouring of emotions. So it's really incredible when you see, when you start looking for sleep-related breathing disorders in women. It is very interesting to see. A lot of them actually have very interesting symptoms which do not reflect on when you do your sleep studies. And I'll show you that. They score lower, definitely, and a shorter duration of apneas. Interestingly, their non-REM AHR is also lower, but a lot of them manifest with REM OSA. Very interesting to see that. And they have more symptoms at lower cutoff values. And we are talking about a younger age group here. And definitely women are more predisposed to upper airway resistance syndrome. So from the data we have actually looked at, so what I've actually done is, I have now put them in 3 different categories. So forget pediatric OSA, but from the reproductive age group and postmenopausal age group. So 15 to 49 and 49 and above, 50 and above. And if you look at it, if you look at the BMI, you can see that weight gain generally increases over time. And also, when we start doing sleep studies, you see less severe results, but as they grow older, as they get above 50, you see very interesting findings. That's when you, so above 50, you're seeing most of the similar symptoms that we see in men. But when they're in that reproductive age group, most of them actually score within mild to moderate, if not normal. So interesting observations that I saw in my group of patients was we're seeing longer sleep latency, and this is in the reproductive age group. AHI scores are higher in REM than in non-REM. REM AHI scores are consistently high. They don't show, very often than not, you don't see positional preferences. And hypopneas are more prevalent than actual apneas. The average apnea range is usually about 5.5. Well, I had one 30-year-old which had a very high apnea with morbid obesity, so that skewed the results a little bit. And average apnea duration is only about 18 seconds. Udia is about 10.12, but you see a lot more hypopneas. And the average hypopnea duration also increases as the weight goes, as the age goes up. So in the above 50 years, you're basically seeing what we see in classic OSA. So very interesting to note that there is something happening in this reproductive age group very different from postmenopausal age group. And here, we will also realize that snoring becomes a more constant feature, right? So why are women a special group? They seem to manifest with different and less severe symptoms. Symptoms they manifest do not relate to breathing dysfunction or sleep disorders. So referrals to sleep specialists or any of us who are dealing with sleep conditions are delayed. And I think because I've now talked about this, I get a lot of my referrals now come from my gynecologists and also my psychiatrists. Are they really more resilient? Are they designed to be actually the stronger sex? Or is there a protective effect in that reproductive age group from progesterone and estrogen? And I think hormonal change here hormonal influences here have got a huge role in this. And we may need, the current standards of diagnosing may not hold true. So we may need different diagnostic criteria, different diagnostic tests in these patients. And because here, right, a lot of it may not be breathing related. They are more often neurological related. They get a lot of autonomic nervous system dysfunctions in this group of patients. And because of that, I personally feel that you cannot use that same treatment protocols for men as in women, like a CPAP or surgery or whatever. Because if you now understand that there's a lot more things going on, try and imagine if a patient having anxiety, depression, panic attacks, and you want to do surgery in them. So we now take our time. You've seen my protocol when we go through the pre-rehabilitation. We work on a lot of preparing the body system before we even think about correcting the surgical point of view. And that is where neural integration comes into the picture. So points to ponder: extraction versus non-extraction orthodontics. Now this is a huge ongoing debate, but if you ask me, very simply put, again, when we talk to patients, we don't realize that our nose, most patients don't realize where the nose is. Most of them think that this is the nose, but the bulk of the nose actually sits above the hard palate. So if you have a skeletal malocclusion that requires orthodontic treatment and you're extracting, you're actually not doing anything to increase the space. You're not making the space smaller. The space is already small. But now when you do that, you're just aggravating the condition because cranial strain patterns and also myofascial tension becomes very, because you're using retainers, you're locking these things into place, and this is where they get much more musculoskeletal problems. And a lot of them actually come to you and you talk to them about their spine issues. The first thing they'll tell you is, yeah, doctor, I've been diagnosed with scoliosis. And interestingly, in a lot of these airway patients, we see scoliosis in about 5 to 10. The degree of bend is about 5 to 10 degrees. It's not those very severe scoliosis. So this is something again to think about. Whether scoliosis is an adaptive spinal curvature from bad posturing from breathing. And then so the increased sleep fragmentations and fatiguity and wake up tired in the morning. These very common symptoms. A lot of them will tell you that they've got headaches. So my neurologist sends now all these patients with tension headaches to me. Tension headaches, almost majority of them will have TMJ issues, and when you test your sleep study, you will pick up bruxism. Alright? And so TMJ issues, bruxing, clenching, these are all very common things that you see in the female population. And then it's talked about anxiety, compulsive behavior, irritability, panic attacks, and depression. And another very common thing is sleep interruptions for toilet visits. So why I feel that we need to get it right. Now this is something that is very important for us to think about. The future generation of good health starts with a healthy woman. Why? Because understanding now that whatever we do, like orthodontics or whatever, if you don't understand this, optimal craniofacial structural development actually begins in utero. From a single cell, the embryo now develops into a baby over 9 months. Now, if that mother is not breathing correctly, and you're creating an environment where the intrauterine environment is actually hypoxic. We saw the previous lecture by Dr. Sharma, we talked about sleep interruptions, how all those various comorbids, why? Because of oxidative stress and chronic inflammation. So now you're growing your child in a hostile environment, and this baby, while growing in this hostile environment, is now going to have a lot more issues, in the sense that they are already developing bad craniofacial structure in utero. Then you have retained primitive reflexes to help the baby survive this environment. Now when they have more and more of these issues, these retained primitive reflexes, we see it as a huge problem when we work on children to integrate this whole system together. So they have these retained reflexes, these retained oral reflexes, which actually are roadblocks when we try to work on rehabilitating this physiological function. And also, because of this thing, we are all now growing in an environment where your neurological system is perpetually on a survival mode, survival response. So these are all things that I've thought about, I've spoken to a few people about it, and it's very hard to prove all these things, but we are seeing it more and more. And if you talk about pregnancy, right? Now there's enough data out there. There's quite a few studies now talking about pregnancy-induced hypertension and diabetes and its relationship with OSA. So the more you look at it, the more you see, the more you realize that it's more work for us to do. So, but the treatment criteria, whether putting these patients on CPAP, who we should treat, how to go about, I really cannot answer those questions right now, because I think there's a lot more research that has to go into these areas. And today, in today's world, one of the things that almost all of us in general compromise is sleep. And all the women here, you all are working women, you all are doing all these kind of things, and when you're pregnant, you're compromising your sleep. See what happens here? Sorry. Okay. Maternal stress during maternal stress during pregnancy alters fetal cortical cerebellar connectivity in utero and increases child sleep problems. So this is something that we're seeing more and more. Your mothers, these are the patients when they come to us and they tell them, they say, your child have problem falling asleep, or they had, they're very hyperactive, they're just very fidgety, they can't sit still. These are all we're seeing in children today. Then, after pregnancy, delivery process. Now, delivery process I didn't want to talk much about, but in osteopathic literature, vacuum deliveries, any instrumental delivery seems to have an effect. And in our group of patients, because we work with an osteopath, our most challenging patients who have oromotor dysfunction actually come from vacuum deliveries. And we even see these kind of changes in patients with babies with cord around the neck, how it actually can change certain things in terms of their primitive reflexes and retained startle reflex. All these things are still, we are seeing this. And then next comes pregnancy and breastfeeding. So we know that breastfeeding has a protective effect or rather it has a very positive effect on developing the craniofacial structure. And these studies are all well established studies. And what is important is they have shown that breastfeeding helps increase that transverse and AP maxillary dimensions as compared to bottle feeding, which reduces those 2 dimensions. So now I'm just going to run through the special populations. The studies are there already in neurology, right? And by chance, I've actually picked up quite a few patients who were referred to me by the neurologist with headaches. Usually it's headaches and with vertigo, and they had a MRI brain done. And one patient was 36 years old, and the amount of white matter intensities was just fantastic. It's just unbelievable. But when you look at the craniofacial structure, she was a skeletal class 3, had 6 teeth extracted for orthodontic work, and she had a very bad posture. But I couldn't convince her that she needed to do something about it, so we did end up doing a sleep study for her. Another patient was a very recent patient, 67 years old, again, headaches, long-standing, was referred to me because of vertigo, had an MRI done, plenty of white matter disease, and the best part is, when I did the sleep study, she had severe OSA, which was completely not picked up by anybody. Very thin lady, BMI of 24, she was 69 years old, but she's already showing signs of early onset dementia. So we really need to open up our eyes about all these problems. This is well established. I think Srinivas had a good chat with Dr. David Day, and he presented a very beautiful lecture on this. And you can see that UARS may be a follow-on sequence to awake disordered breathing. That's very interesting, because from awake disordered breathing, you will see that all the symptoms that I talk about are all the small circles around UARS. And this is predominantly a female disease. So again, something to look at. PCOS. Now, I've had so many patients who come to me. These are all 20s and 30s with polycystic ovarian disease. They come for some other reason, and if you ask them for sleep disordered breathing symptoms, they all have it, because obesity, it's all there. So it's another special group of patients we need to look at. Cancer, I think Somta is talking about it. In fact, I've actually quoted his paper there. There's, again, no surprise. Autoimmune disorders as well. Now, there are studies showing influence of dysfunctional breathing on autoimmune disorders. And a good number of patients, which I see in our patient group, including those with SLE, rheumatoid arthritis, and if you actually look for symptoms of sleep disordered breathing, they are there. So whether it's a cause and effect story, we really don't know. Fibromyalgia, well established, 50%, again, cross relationship, we don't know whether it's one causing the other. But again, here from example, we have actually treated one patient through an integrative therapy with neural integration, and she's now, her last pain injection cocktail she had was May last year, and she's been relatively doing very, very well, and we've also reduced the psychiatric medications. Very complex case, post-traumatic stress, depression, anxiety, panic attacks, and fibromyalgia was actually triggered by trauma. So by treating her with this, she's actually now doing very well. Her nose is obstructed and she needs skeletal expansion. It took us 1.5 years to prep her to take her to where we are, and I'm doing the surgery next week.
I hate to interrupt you, so you're down to the last 1.5 minutes.
Last minute. And mental health. This is the last slide. Mental health will be, I think this is something that now more and more of my psychiatrists are actually seeing this, because we see young women with depression, with anxiety, and now they realize that it's actually a lot of it has to do with sleep disorder. And then they said to us, and believe me, I don't think it's just pure OSA. A lot of it has to do with sleep hygiene. A lot of it has to do with many, many different aspects of sleep itself. But I think we really need to focus to improve their sleep health. So in conclusion, sleep breathing disorders in female is an enigma. And I think there's a lot more work to be done in this field. Awareness is poor, not in our field, at least now we are becoming more aware of it. And I think we need to encourage, to educate our colleagues who are dealing with this. And I think a lot of the symptoms are because of compensations and adaptations. Studies are not adequate at present. And the diagnostic criteria, as I said, we may need to relook these diagnostic criteria and treatment protocols. So that word there, men are from Mars and women are from Venus, I think sleep disordered breathing is beginning to look like that. And this is why it's difficult, because just like in anything else, women never tells you straightforward what it is. We have to go digging for it, finding out what's actually going wrong. Thank you.
Thank you so much.